TOP is a preventive early intervention program to strengthen the resilience and development of very preterm infants and their parents after discharge from hospital. As you asked us how we got there, we will first try to go through a little bit of history. About 20 years ago, my colleague Marianne Wolf and I were struggling with what we had learned in what we had learned as pediatric physical therapists and what we saw and intuitively felt in early intervention practice. Preterm infants appeared uncomfortable, easily stressed, and their problems seemed complex but very difficult for us to make objective. And their parents seemed to need much more or perhaps different kind of support than that was available at that time. Follow-up studies taught us that these infants' problems might be precursors of the multiple mild disabilities that children have at later age. So we decided to search for a more integral approach to early development and intervention, and that might perhaps better match their needs. And that is actually what we're still working on today. Once on this path of search for a more integral approach, we were very much inspired by the work of Dr. Brazelton. During our training, we learned how infants integrate different neurofunctional domains in order to respond to their environment and how to customize our response and our reactions to their individual strengths and vulnerabilities. And we were also very, very interested in Dr. Els's synective theory, and we thought we wish we could have something for older infants. Then we searched the internet and found the IBA-IP by Rod Hedlund, and we went to Seattle to meet you. And we were really thrilled to find that Rod had developed an assessment and intervention program that was drawing on the work of Dr. Brazelton and us. So we went back to Amsterdam trying to find support, but that was very difficult to start because it was found too much of a risk as the program had not been studied before, and that's always the problem when you're starting something new. Fortunately, we found at last 4 other pediatric physical therapist pioneers who wanted to invest in a training, and after many rejections, Marianne finally found a little grant to start a pilot study. So Rod could come over, and that was the beginning of, and I'm going to show you the next slide. That was the beginning of more than 10 years of training and research and follow-up activities. The IBA-IP gave us new eyes and an enormous motivation to continue our work in this field. Of course, all these activities also led to intensive interactions with parents and children and trainees and interventionists and other professions or intervention programs. Oh. Oh, that's not mine. Oh, here I see Karen here. Perhaps you can. Yeah. Oh, that's the end again. Can you go up? It's in. Yeah. I think we were. Yeah, activities and interactions. Interactions. No, we're in the end again. That's strange. You have to go up again? Yes. Okay. Yes, thank you. Okay. Of course, all these activities also led to many interactions. At the same time, in the same period, exciting new advances in sciences were published about the impact of early experiences on the brain, the negative influence of stress and the positive influence of nurturing environments, and there was much new information about the role of self-regulation and executive functions on cognition. We also learned about, what can I do about it? Perhaps okay. Okay, now I know what to do later. Thank you. Oh, shall I? Oh. Yeah. I think it's 5 or 6. 5. Number 5. Yeah. We learned from prevention studies that intervention should. Oh. Oh dear. It's okay. Of course, you will know that interactions and information gradually leads to brain development, and I think that's what also happened to us during those years. We definitely found that we were on the right track, but it was time to create an innovative intervention protocol and a new training curriculum that integrated all those new experiences and those important new advances in sciences to further improve preterm infants' developmental opportunities. And then the TOP program was born. TOP is a preventive support with holistic vision for all very preterm infants and their parents in the Netherlands after discharge from hospital until 12 months corrected age. So 6 months longer than in our RCT, to give support when the brain is sensitive to develop the conditions for behavioral and mental development. They received 12 home visits carried out by pediatric physical therapists with 1 year of TOP training, or they have the IBAP plus a TOP additional training. TOP provides continuity as a TOP interventionist supports the family for 1 year. The program also has a special organization about which Marijan Wolf and Anna Kruger will present this afternoon. The TOP interventionist has a comprehensive mission. Their primary tasks are to empower the parents to build a reliable and responsive relationship with their preterm infant, signaling problems in infant or parent and give timely intervention or give help to find it, using a strengths-based approach, bridging the gap between parents and other health professionals. And in the next slides, I will try to summarize how TOP training prepares the interventionist for these competencies. So our first goal was to empower parents to build a responsive relationship, because responsiveness, I know what to do. Where is it? I can't find the... Perhaps when you put it on the paper? Oh yeah. Here. Oh. Responsiveness is essential for children to engage in life without stress. And to guide parents' responsiveness, we created an instrument that defines the elements of the infant's behavioral communication, as well as the elements of a reliable and responsive relationship. On top you can see the 3 categories of behavioral expressions of the infant: drawing on Brazelton, Els and Hedlund, information seeking, self-regulation and stress. And behind each category we defined a large variety of behavioral strategies from all 4 neurofunctional systems for infants from 0 to 12 months. In blue below you find the 3 qualitative elements of a responsive and reliable relationship that correspond with these behavioral expressions. Now, on the right side you see protection, providing warmth and safety and preventing or restoring internal disbalance. In the middle, respecting and supporting the child's self-regulatory strategies, and on the left side continuing the interaction by adding information in a scaffolding way. Now the interventionist is expected to absorb the model in order to support the parents from moment to moment. So it's not used to score and give intervention afterwards. Thus, guided by the parents, the infants are supported to explore and participate in increasingly complex situations during their first year. However, preterm-born infants are known to have problems, and also the parents, and these parent-infant interactions may be influenced by many factors. Therefore, signaling problems is an important competence of the interventionist. The infants are known to have multiple mild problems which have a negative influence on their internal balance and on their possibility or their opportunity to explore their environment, and although their parents are known to experience problems themselves. And therefore we developed a SWOT. We use a SWOT model. Are you familiar with the SWOT model? Yeah. To collect all these factors that influence the infant's developmental opportunities. Like in the ecological system theory by Bronfenbrenner, you will find that it contains the internal factors of the infant and also the external factors of the parent and the wider environment. And according to the transactional model by Samerov, the different factors may be a challenge for the infant or may have a protective influence. And this is shown by their allocation to the left or the right side. So the parent-infant relationship is put in the center, as all these factors influence the infant via the parent-infant relationship. Now this SWOT model makes a holistic vision of the top program concrete for the interventionist, helping them to be aware of all the factors with a positive or negative influence, and to realize their dynamic interplay, because they may cumulate in a positive or a negative way, or they may give compensation to vulnerabilities. Now, all the materials of the top training include the background series. They also include the scientific information on neurobiology and evidence information on all the factors influencing the infant's resilience and development. The SWOT model also helps to give genuine individual developmental support, and it helps them to use a strengths-based approach, which includes not only the strengths of the infant but also the capabilities and the resources that are already available in the environment, which you can find below. Supporting the parent is a very important part of top training. We think a strengths-based approach is essential for the feasibility, but also for the effectiveness of the program. Empowering the parent cannot be established by only cognitive information. Parents need also emotional experiences. And the strengths-based approach increases the parent's curiosity and feelings of pleasure and satisfaction and motivates them to do what's best for their infant. It also supports a good working relation between the interventionist and the parent that is based on respect and equality, and which and to help and to give family-centered care. So training in the strengths-based interactions is therefore worked out carefully during training, and also in the manual we have, in order to translate what we know, what we have to do, and how and what we do in practice. Now this bridging competence entails, for instance, providing regular written reports to the clinician about the strengths and vulnerabilities of the child, ensuring that parents understand the information from other professionals, providing proactive psychoeducation to reassure the parents, but also to inform them how they can seek opportunities to get help for themselves. Or, for instance, providing support and information when parents have to go back to work. Well, that's something that is more of an issue here than in Sweden, of course. Well, all these elements are all part of top training. Our training is a stepwise education during 1 year, in which we grow with the infants from 0 to 12 months. It starts with a visit to the NICU and the follow-up clinic, which they organize themselves in their own region and preferable with the hospital they expect to go to work with. It's followed by 13 contact days, first 2 days and then 1 day a month, in which we intertwine theory and practice. Usually we do theoretical presentations in the morning, and we have practice with a lot of video used and other educational methods in the afternoon. So they're always working and reflecting on their own observations or their own interventions. The trainees are expected to do 1 preterm observation or intervention a month, and they are observing a full-term born child during the year. 1 year long they are following this child. They receive a high level of individual support. They do literature study, and in total it costs them about 300 hours. It costs them a little bit more than 5,000 euros per person, and we will talk a bit more about the sustainability of the program this afternoon, but the interventionists do support ongoing, get ongoing support after their training. We think that's very important, and we also train new trainers. We do not have a special program for that, but they are growing with us in the material. I'm nearly there. We think it's likely that this program is transferable to other countries with other models of care, but of course it will need some adaptations which have to be discussed then at a certain period. And I'd like to end by thanking you for your attention, and also we would like to express our gratitude to Dr. Breeston, Als and Roel Hedlund, without whom the program would not have existed.
Thank you very much.